Oh, thank you very much, Sam. So, well, uh, these are my disclosure. I would like to challenge you to come with me in a journey. So, how you imagine the surgery in the future? How artificial intelligence are going to help us to improve our outcomes? How we imagine to teach young surgeons? So, I'm going to try to answer a little bit of this question. So, I'm going to challenge you to come with me in a journey where we can try to understand a little bit about that. Talking about education, we just changed in 2003 the way that we teach surgeons. Use the Halsted method, and we know that it doesn't work as well. We use nowadays the Peyton deconstruction method, where for laparoscopy is a very good way. And we also know that the majority of surgeons learn more with kinesthetic way of learning instead of visual or audition or read and write. And this is a very important thing, because in the past, everybody start to learn anatomy on the book. Few of them nowadays are able to dissect a cadaver, but this is the library of the past, and this is the library of the future. Everybody can have a library on your own cell phone. It means that education is changing a little bit. And the most important thing when we talk about surgery is about the consensus. Some years ago in Brazil, we asked for a specific question for very good rectal surgeons, where they place their trocars. And 5 of them, and 5 different questions. It means that how we are going to teach if we don't have a standardized procedure. So the most important thing is standardize the procedure first, create the triangles, and from there, we are going to be able to teach all kind of the procedure. And more than that, how artificial intelligence are going to help us to standardize the procedure or even teach people. Who has iPhone 10? Is a facial recognition iPhone. Is that correct? Computer is going to start to do a facial recognition of the surgery. This is a work developed in INERCAD in collaboration with Hopkins and other universities, where they put together 100 videos of cholecystectomy. And the computer machine were able to detect all the phases of the surgery and create a pattern where now we understand what means good surgery and what means bad surgery. And how this is going to help us to do our job. Because if you have a machine attached to your camera, this machine is going to help you and say, hey, doctor, don't go there. You have the choledicus. You are going to cut it. You can have a biliary injury. So this probably is going to be the way of interaction, what we are doing, and what's going to be the future of the surgery. But the most important thing on that, when we have a machine helping surgeons to do things, is that today, we are able to teach skills. We are not able to transfer experience. With the help of the machine and the experience of millions and billions of videos on Word, the machine is going to give to the young surgeon experience enough for good decisions. It means that in a further future, we are going to have and transfer experience also. Well, computer work with patterns, so they recognize patterns. It means that we can recognize patterns from radiology, we can recognize patterns from histology, and we can recognize patterns from any kind of view, like the view that we can see over here. The vision of human eye is only the laparoscope view, but we can combine all the visions together, and the machines can provide us all of this vision during the procedure. The most challenging thing is exactly how to attach all these models during the live procedures, because we have challenge. You want to recognize the nerves for pelvic surgery. We don't want to damage them, because we want better functional outcomes. Much more than that, the combination of 3D virtual image with video image, the reality, is not so easy, because when we do laparoscopy, we insufflate with CO2. All the structures change, and so it's not easy to combine and have augmented reality. And we face a lot of challenges for doing that. We also have the breath movements, and all tissues has its own personal coefficient of elasticity. It means when you grab something, everything changes. So how we are going to wait or to create some tool to navigate through the abdomen? Well, it can be done in open for liver surgery. It can be done in some specific case, but nowadays it's not automatized. But we want something automatized. Maybe combined with robotic tools that nowadays we think more in mechanics than in intelligence behind of the robotics. But I can guarantee you, in the next years, robotic is going to be only 20% and mechanics and 80% intelligence behind of the machine. And much more than that, a lot of companies are coming to work on that. So navigation is another thing. Navigation is very important. Nowadays, the majority of us, even knowing the way that we go from our home to the work, we use an app because we want to know in real time what is happening. In knowing the way is exactly knowing the anatomy. But even if you know the anatomy, you can have challenge. So it means navigation is a very important thing. And maybe this is going to be a way to create a detour for a better way and a better outcome. So what we're looking for is to combine navigation with augmented reality. And navigation is not new. You can do it in a brain. You can do it in orthopedics. You can do it in some place where it's totally closed and it never changes. Because accuracy should be less than 1 millimeter. If you have an accuracy more than 2 millimeters, it's not a good system for navigation. Imagine doing that intra-abdominally. So some guys are trying to develop this for ablation in liver. Some start for transanal dissection. And we are also pursuing this idea to identify the pelvic landmarks to avoid damage to the, important structures. Imagine if you have a fat patient, BMI 42, where you have to guess through the fat where is the inferior mesenteric artery. But if you have a navigation tool, you are going to go directly to the origin of inferior mesenteric artery. It's going to be easy for you for a good technique. So this is one of the challenges and what we are trying to do. We have a lot of challenges because when we change the table, we change the leg of the patients, everything changes inside. A lot of information that we have to work on it and create a better way to understand what we are doing. And this is one of the last papers that we published in surgical endoscopy, exactly saying and showing the way that we are pursuing or researching the way to combine these things with what we are doing in the day by day. I believe that is not is a little bit far away from the routine news, but if you have this combined with machine, combined with artificial intelligence, and all the views that the machine can provide to you, and imagine all the data behind of experienced surgeons for low anterior accession, several videos that machine are going to be able to warning you, don't go there because you are going the wrong plane. This is going to be probably the way that we are doing that. And this is what we wrote in the past. And we really believe the navigation and also the way that all this new technology combined is going to change the way that we are doing surgery. And the most important thing is that the transfer of experience is going to give more safety for our patients, because we are pursuing safety and good outcomes. But we can never forget that behind of the machine, sometimes it's better to have a human factor. that can, with a good decision, save several lives. Thank you very much for your time.